My name is Adina. I am a oncology certified nurse. I was working in business management and marketing for the first half of my life and transitioned into nursing in early 2000. I graduated San Diego State School of Nursing with my Bachelor's of Science in 2009 and got my oncology certification in 2013. I knew very early on in nursing school that God was calling me into the field of oncology, as my dad was diagnosed with colon cancer and my best friend's husband was also diagnosed with cancer. So I knew very early on what field I was headed to. I did the first 7 years as a nurse working permanent staff jobs full-time and then transitioned, all in oncology by the way, and then transitioned into travel oncology nursing so I could see how other areas of the country took care of their oncology population. So I was able to work at some amazing facilities. Some of them you probably have heard of. City of Hope out in Los Angeles, Duke Cancer Center up in Durham, the James Cancer Center at The Ohio State University, and the National Institute of Health up in Bethesda, Maryland. I have done the inpatient hospital setting for 8 years. I've done outpatient clinics. I've done infusion centers. I have done clinical trial units. So I definitely understand how the system works. And I can definitely understand why some of you might be frustrated. So that being said, let's talk about patient advocacy. So what does patient advocacy mean to you when you first hear those words? What comes to mind?
Speaking up, being the voice for your loved one.
Being the voice for your loved one. Excellent. Anyone else?
Finding out all you can about different sources of information, where to go, how to help people access those information sources.
Exactly. How to help people access information, being resourceful, all excellent options.
Standing up for their rights.
Yes. Standing up for their rights, making sure they're heard, right? All right, so patient advocacy, you guys nailed it, being the voice of the patient and standing up for his or her rights. So assisting patients and helping them understand the medical plan so they can decide which scenario fits their best interest, right? Just because a patient has been admitted to the hospital and the doctor wants to do surgery doesn't necessarily mean the patient's interested in that option, right? So it's about taking the time and having those conversations. So I like to keep it simple and say it's a second set of eyes and ears for the patient. Okay. So in regards to Alzheimer's disease and other diseases that fall under the umbrella of dementia, it is very important for that patient to have an advocate, if not two advocates, right? Because what one person hears, another one might miss and vice versa. So let's talk about why a patient advocate is needed. So has anyone ever bought a house? Raise your hand if you've ever bought a house. Right? Been there, done that, bought the t-shirt. So say you are looking to buy a house and you take someone with you, right? Whether it's your spouse or your sibling or your best friend, or you take someone with you, right? You don't go by yourself because it's an exciting time when you go to buy a house. And so you're looking at the house and the real estate agent's walking through the house with you. And the real estate agent pauses in the kitchen and says, so just so you'll know, the seller is willing to come down $10,000 and offer a price reduction on the house because they know the kitchen is outdated. So they want to give you that money so you can update the kitchen should you buy this house, right? So what do you start thinking about, women?
What else is wrong with this?
Okay, well, that's not where I was going to go. But, you know, we start thinking, or I would start thinking, okay, I could change the cabinets. That means I get new appliances. I wonder what color, and let's talk about the backsplash, right? My mind just starts going. Well, as my mind is going, and off in another tangent, what I miss the real estate agent say is, however, the roof does need to be replaced, and they are not offering a concession for that. I missed that part because I'm out planning my new kitchen, right? So very similar to having a patient advocate, right? What you hear may be very different from what someone else hears, because as the doctor starts to explain things to you and starts to answer your questions, right? Your mind starts going off on these tangents, right? So let's talk about different options or different scenarios here. So a new diagnosis, right? That can be shocking and overwhelming. I think of my good friend Jennifer out in California. She was a mother of 3 children. She ran her own photography studio. She was a public speaker. She was a published author. She was a very competent individual. When she was diagnosed with breast cancer, she reached out to me and said, Adina, can you go with me to my appointments? Of course, right? She's been one of my best friends for years. Of course, I'm going to go with you to your doctor's appointments. So we go to the very first appointment, and she's engaging in the conversation with the doctor. She's asking questions. I'm asking questions. We're gathering information, right? It's a good visit. And then we drive home. And as we drive home, she goes, what just happened? And I go, what do you mean by that? She goes, what just happened? She goes, I know we were talking to the doctor, but all I can remember is I just had my first visit with an oncologist. She goes, I can't remember anything we talked about, right? Because it's overwhelming. I said, well, that's why I'm here, right? I'm your second set of eyes and ears. So maybe it's abnormal lab results. Those can be scary, right? If your kidney function continues to climb and your doctor's starting to get concerned and you're diabetic with increasing kidney function, that can be scary. Maybe you get a scan, right? Us lovely women get to go in for our lovely mammograms, and maybe the doctor says, hey, we saw something. Not sure what it is, but we want to do a biopsy. It could be a cyst. We're not sure what it is, right? All you heard was biopsy and your mind just went, right? Or it could be a change in a disease, right? A disease course can be complex. So I think about my mom. My mom has dementia, and she also has high blood pressure. And I was up there visiting her in Maryland, probably over 2 years now. This was pre-COVID. And she started complaining of a headache. We checked her blood pressure, like stroke level, 200 over 100. And I'm like, well, we're just taking you to the emergency room right now. So took her to the emergency room. They were able to get her blood pressure lowered without having to admit her. And they said, follow up with a cardiologist. That takes several weeks and months, right, to adjust medications, right? And so they had to make several changes to her medications to get her blood pressure on track. So she went from one medication to a different dose of a medication to now that medication is twice a day. Then they added a second medication, right? All those changes start to all blur together, right? So it's hard to sometimes remember what is the most recent plan. Luckily, I was there with her and was able to help keep her on track and help get her husband up to speed because he was at work. So all those reasons are examples of why we need an advocate. Okay, so who is an advocate? First and foremost, it's the patient, right? We can all advocate for ourselves. It could be a spouse, it could be a family member, it could be a close friend, it could be a nurse. It's one of a nurse's primary jobs is to advocate for their patients. Be a social worker, a discharge planner, geriatric care manager, if your facility has one. It could be a paid consultant. Not everyone has a support system, right? So sometimes they have to pay out of pocket to get some help. It could also be a patient advocate on staff at the hospital. All right, so let's talk about, so it's pretty much anyone, right? Anyone can be an advocate, you would think. Let's talk about the characteristics of a good patient advocate. So helpfulness and resourcefulness. So a desire to help is the most important asset when it comes to being a patient advocate. Okay? Advocates must possess a natural sense of caring for people and empathy for what patients experience throughout their health challenges. Wanting to help and be of service is the driving force that propels patient advocates, making them extremely resourceful and willing to go the extra mile for the patient's best interest. Okay. a good communicator and a listener. So patient advocates must communicate with a wide spectrum of people, from the patient to their families, to doctors, to nurses, to health insurance companies. And they also must be able to listen effectively to patients and to present the concerns of the patients to others in a way that causes the other people to want to work in favor of the patient's wishes, right? You need to be able to dissect information. Medical information is complicated, right? They need to be able to ask good questions. If something's unclear, ask questions. Or my favorite is the phrase, "What I heard you say is," right? A lot of times when we're in healthcare, we're so busy trying to get stuff done, we talk way up here. They need to be organized and skilled at time management. So keeping track of a patient's concerns means the patient advocate needs to stay on top of details, keeping records of the loved one's plan of care. And time management skills are also necessary to ensure that every patient's care is well coordinated. You also have to have good time management so you don't neglect yourself, right? You got to take care of you so you can take care of others. A solution-oriented problem solver. I love the solution-oriented part because many times in the hospital arena, we are well aware of all the problems in the system, right? But to help us find solutions to the problems is key. I will say, I forgot to say this in the beginning, I do have handouts of these slides. So if you guys would like this information when y'all leave, you guys can grab a handout. For those of you on Zoom, Kina can email that to you or attach it to the chat box. So a solution-oriented problem solver. So a patient advocate is likely to be faced with problems constantly, as problems are what patients need help with. A patient advocate must not be afraid to tackle these challenges and be willing to find creative solutions through mediation and negotiation. This might require a degree of creativity. Part of problem solving involves having research skills because patient advocates, much like detectives, must dig up information that can be helpful to patients. As much as we like to think Dr. Google is our friend, it is not always true. A caveat, I will tell you, you can find anything you want to hear on the internet. Okay, so I'm just going to let that rest with you for a minute. So just know you need to find reliable sources of information. Okay. Another good characteristic is a patient advocate has to have patience and strength under pressure. The patient advocates must be able to hear the concerns from the patient. They must use their role and have strength in their role and patience to handle what the patients are experiencing and expressing to them. Okay. A patient advocate must be able to put the patient's wishes above their own desires. Okay. A lot of times when we come to a fork in the road, maybe the patient wants to decide to be DNR and wants to go home. They don't want to do surgery. Well, their family members might not like that decision. But if that is the desire of the patient, we sometimes have to put our selfish desires aside and listen to that of the patient. Now, there are some nuances with that, right? Is the patient just tired, dehydrated, confused, right? Do they just need a couple days rest and let's re-examine the issue once maybe they feel better and the antibiotics have kicked in, right? And another characteristic is you have to be able to take care of yourself, which we talked about a minute ago, so that you can take care of your loved one. Okay? So, who needs a patient advocate? So, have you guys heard the expression, it takes a village? Right? It takes a village. We often hear that phrase when we talk about raising children, right? It takes a bunch of people to raise children. But that expression isn't just for child rearing, right? How many of us, you know, when life gets stressful, want to go out and hang out with our friends and, you know, go help someone mow their yard or whatever that looks like, right? We are not created to live in isolation, right? We are created to live in fellowship. So the same thing goes with patient advocacy, right? It takes a village. We cannot expect to do it all. Sometimes we need help, and sometimes we help others, right? It's kind of a give and take. So who needs a patient advocate? So anyone with a major medical diagnosis. So that would be cancer, Alzheimer's, Parkinson's, heart disease, diabetes, right? Those are all major medical diagnoses. Anyone with memory issues, right? Anyone over the age of 70, right? Now, that's a blanket statement. I'm not saying everyone that's 70 and older necessarily needs an advocate, but for the most part, by the time you hit 70, you're mentally not as sharp as you once were, right? And so having a second set of eyes and ears is just helpful. It doesn't mean your patient advocate's going to take over your healthcare. It's just a second set of eyes and ears. So anyone that gets stressed out easily, anyone that gets anxious quickly, anyone that's overwhelmed, right? If you're already overwhelmed and having to go to the doctor, it's like your cup's already overflowing, right? Anyone with white coat syndrome, you all know what white coat syndrome is, right? So seen it thousands of times. Patient's doing great, they come in, they take their vitals, their blood pressure shoots up, the doctor walks in, deer in the headlights. So what are your questions? I'm good. Right, so white coat syndrome, bring someone with you. We're all human, right? And then anyone having difficulty managing medication, right? So there's a thing in medicine called polypharmacy. So polypharmacy can occur quickly as we have major medical diagnoses or other comorbidities, if you will, other complex diseases. Maybe you have blood pressure issues and you're diabetic, right? So polypharmacy is the concept of multiple medications, and those medications all have their part, but sometimes certain medications, when they work together, produce a different result, right? So if you're having trouble managing your medications, you can't remember what this medication's for, all reasons to have a patient advocate. So let's talk about the in-hospital setting. So I like to tell well, I don't like to tell this story, but I do share this story. When I was working out in California, I was out there for about 8 years, and I was strategically given this patient assignment, and the patient was not doing well, and he had a large family, and they were told the day before, the evening before, your dad needs surgery. The doctor will be in at 5 a.m. to explain everything. So the family went home, came back. They were there by 5 a.m., all 5 of them, plus the patient. So the room was full. And the doctor didn't show. So 5:30 comes around. The family starts getting a little vocal. Nurse pages the doctor. No response. Right? 7 o'clock rolls around. Getting a little more vocal. Still no response. So I come on shift at 7:30 to get report on this patient, look up the information that I need to look up, knew what I was walking into, and walked in, introduced myself, sat down, right? So I'm eye level with the patient and their family, and said, I hear you've had an exhausting morning. Tell me about that. And so I gave them the opportunity to vent, to share some concerns, to get out their frustrations. And I just sat and listened for about 5 or 10 minutes. And I said, I understand. I totally get it. I said, I just want you to know, I've already paged the doctor, and I've already talked to my nurse manager. So I'm going up my channels, and she's going up her channels, and we will resolve this. You will have an answer soon. And so I just continually checked in on them. The doctor ended up coming in just before 9. I know, it's very frustrating. So in the hospital setting, things move at lightning speed, right? And so what had happened, and this is exactly, what had happened was they had anticipated surgery for this patient, and then the radiologist called and showed them something on the scan. So the radiologist was talking to the doctor. Doctor realized surgery wasn't an option. So in the doctor's mind, the patient wasn't as acute and critical in regards to that 5 a.m. meeting, but it never got communicated, right? He came in, he apologized profusely. It ended up being fine. They came up with a plan B. Patient was discharged 3 or 4 days later, safely, with a plan to go home. So being authentic and transparent, I think we do better, but we still have a ways to go, okay? So when a patient is admitted to the hospital, there's an admission process, right, that has to go on. So typically a patient may come in through the emergency room, especially if it's in the evening, and the emergency room either decides they're stable enough, they can be seen outpatient with their physicians, or they need to be admitted. If they're typically admitted, it starts a whole process of admission. And part of the admission process, typically done by the nurse, some facilities have an admissions intake nurse, is the question, if they're by themselves, is there someone that you want us to call and notify to let them know you're here? Or do you have a family representative that you want us to communicate with, right? So that's part of the admission process. Now, when it comes to staffing, I just want y'all to understand there's different levels of care at the hospital, right? There's the ICU, there's a progressive step-down unit, also called a PCU. There is a med-surg level, right? The state of California is leading the pack with staffing ratios. They've passed they passed laws to mandate nurse staffing ratios. We do not have federal guidelines for nurse staffing ratios. They are going through the legislative process once again to create those. If y'all want more information about that, you can Google the last pizza party, and there's information there on trying to create federal staffing ratios throughout the country, so it's more evenly divided. So an ICU nurse typically has 1 to 2 patients. These are people who are critically ill, life or death situations on a ventilator. Progressive step-down units typically have maybe 2 to 4 patients. And then a med-surg floor could have 4 patients, but they could have up to 6 or 7, depending on which state you're in, depending on that facility, and depending on staffing, right? So I share all this with you to let you know it does get very complicated quickly when you're admitted to the hospital, right? And so say I was a med-surg nurse and I had 5 patients to take care of that day. They try to staff based on acuity, right? So you don't have 5 critically ill patients because that would be so unsafe, right? So they try to break up the acuity, if you will. So you might have a few independent patients. You might have some that are questionable, could teeter one way or the other. And you usually have 1, if not 2, that really need your attention, right? So to be boring in the hospital is a beautiful thing. I'll just say that. All right. So how to help your loved ones when they're in the hospital setting. A couple things to remember. Everyone is working for the best interest of the patient. The nurse is working for the best interest of the patient. The doctor is working for the best interest of the patient. We take an oath to do no harm, right? There's usually so much going on behind the scenes that many times patients and family members don't see it. You don't want to see it, trust me, right? And the other thing I will say is just be gracious, right? Everyone makes mistakes. Be gracious. Because you don't know what that nurse is dealing with, right? I mean, she could have, and I've seen this happen, so I don't want to say this is the standard, but it does happen. You know, she could have just done CPR for 5 or 10 minutes on a patient and had to transfer that patient to ICU. Meanwhile, someone's sitting on the call light because they want another apple juice, right? She's going to have to balance that, right? She'll get to you as soon as you can. Now, there's a difference between a delay and negligence. I will be very forthright with that, okay? But just remember to be gracious. And then the other thing I want you to know, and nurses don't always like the whiteboard because in the big scheme of everything they have to do, updating the whiteboard really isn't high on the list of things to do unless you're in management, and then it's a priority. So, but if you're the patient advocate, if you're the spokesperson for the family, make sure your name and contact information is on the board in case the doctor does need to talk to you, in case the patient does need to be transferred to a higher level of care, they need to be able to reach you. Now, when you're in the inpatient setting, knowing that the nurse is taking care of 5 to 7 patients, you need to choose a family spokesperson. You cannot expect the nurse to call the spouse and all 3 adult children. She cannot update everybody. So it's not that, there's a pecking order or anything like that, but the nurse is limited in how much she can communicate, right? So it's just kind of part of that teamwork. If you're going to be the patient advocate and you're the point of contact for the family, you are taking on that role to help disperse information to the rest of the patient's care team. And then clarify what you heard. Kind of what I said earlier is, so what I hear you say is, right? We call that the teach back method in medicine. So sometimes the doctor will share a bunch of information, and when you tell them what I hear you say is, then they can let you know, yes, I said that, but this, and this, right? So she's kind of making sure you're connecting the dots and closing the gaps. And then plan for the hospital discharge, right? Because no one's going to stay in the hospital forever. So my encouragement when it comes to a discharge is don't let the discharge be rushed, right? So much focus is put on patient safety while the patient's admitted. But when it comes to a discharge, sometimes it takes a while for the doctors to put all the discharge orders in. And then once all the orders are in, boom, let's get them out, right? So don't let the discharge be rushed. Ask for time to review the discharge paperwork ahead of time, because the nurse and the discharge planners, they've seen this paperwork. They know the format. They've seen it thousands of times. But for you, that's your first time seeing that, right? So if you can ask them to print out the discharge paperwork ahead of time so you can look at it before they go over it, just creates a safety net, if you will. And then it allows you to, write on it and ask, put your questions out there. And then sit down with the discharge planner or the nurse and review the paperwork. Make sure you know the plan, right? Make sure to ask questions regarding follow-up care, especially if the patient's being discharged Friday at 6 p.m. Okay, well, what happens if the patient takes a turn Friday at 10 p.m. or Saturday morning at 9 a.m., right? The primary care doctors aren't in on the weekends, right? So make sure you ask questions about follow-up care. Make sure you have the phone numbers that you need. It should all be in the discharge summary. There's so much now that's in the electronic medical record that there are a lot of stopgap measures to protect that. And then don't assume anything, right? Don't assume that, well, I gave them permission to go ahead and fill the patient's medications here at the hospital pharmacy, and they delivered all the medication. So I'm going to assume that all the new meds are in this bag. Don't assume that. Go through them. Make sure the new medications that are on that discharge summary are actually in that bag, because what if the doctor put an order in after the pharmacy filled the prescriptions, right? You don't want to get home and go, where's your pain medicine, right? So just go through everything. Don't assume anything.
Question.
Yeah.
In regard to discharge, had an instance where my wife, I didn't agree with their assumption of discharge. So there was a Medicare helpline you call. Is that right? Is that right?
Medicare does have a helpline.
And they did a quick review. I mean, it all took a couple of hours, and they came back and agreed with my assessment. I mean, they talked to people and made their assessment, but that I didn't know that was a part of the situation. So I don't know whether do the discharge papers give you that option and tell you that on the paper?
The Medicare,
Yeah, it's
number?
your Medicare patient.
yeah.
Okay.
I don't know, every system's different.
Either the social worker looking into that, who is at the hospital, let it work.
Yeah, every hospital system is different, and that's, that's kind of the confusing part, right? The system that you might be used to here might be different when you're on vacation and something happens, say in Texas, right? Different systems operate differently, and different states have different regulations, right? So it just makes it more confusing. So when to escalate concerns?
You make it sound easy in terms of discharge.
It's not easy.
But what I've experienced is very often the discharge paperwork, or a lot of the paperwork, is just boilerplate.
Yeah.
And it does not refer to my husband over here or my mother over here. And to get people to calm down and slow down, tell me how to do that.
Right.
Because there are I tried to slow down a nurse when my husband was being discharged from a facility, and she said, "Well, I don't usually work here. I don't know."
Well, then I need you to get me someone that does.
This was a nurse, and I finally got the information I needed, and I saw her in the hallway as we were leaving, and I said, "Don't you ever tell anybody that again, because you're wearing the uniform, you're wearing the name tag, you're saying you're working for this hospital situation. Just because you work for X hospital across town most of the time, and you're kicking in your time today, does not mean you don't know. You're supposed to tell me I don't know.
Right.
Don't you ever say that to anybody again." I really let her have it. If she hadn't been in the hall, I probably wouldn't have said anything, but I happened to trip over on the way out. I was really frustrated.
Yeah, so I emphasize the discharge process because that's when things get rushed, right? Because the emergency room is full of patients. They need that bed. And so this is when rubber meets the road and the patient advocate has to stand firm. I'm overwhelmed. I don't understand what's going on. If you don't have time to go through the discharge summary with me, I need you to find someone that does. And just put your foot down. They can't force you to leave, right? And you can, in the hospital setting, patient safety are big words, right? For the safety of this patient, I need you to slow down. Okay, so let's talk about escalating concerns. So delays in care, right? That's when you would want to escalate concerns. So it's not just the apple juice is always late. It's right? Surgery's been pushed. Surgery's been pushed. Surgery's been put. Okay, now surgery's tomorrow. Can he eat? Can he not eat? Why was surgery delayed, right? All these questions. So delays in care. Patient safety. If you ever feel that the patient is not in a safe situation, that is a flag for escalating concerns. And when the patient concerns aren't being heard, right? So let's talk about how to do that. So in hospitals, we have chain of command. Anyone that's been in the military understands chain of command, right? So it all starts with the nurse, right? And usually, if you say, look, I'm overwhelmed, I'm going to be the primary caretaker for my dad when he goes home, and I need you to sit down with me and talk me through this, and I need like 10, 15 minutes of your time. When can we do that? Let her figure out her schedule. It may be the resource nurse that comes in and does that for the nurse. It could be the charge nurse that comes in and does that for the nurse, but make sure you're clear on the discharge plan. Okay, so it starts with the nurse. Then there's always the charge nurse. So the charge nurse is like the manager of a department store, right? They're taking care of that shift, right? They're managing the shift. They're in charge of the shift. They're in charge of the nurses, they're in charge of the medical assistants, and they're taking care of admissions and discharges, and they're just working on the flow. From the charge nurse, there's the nurse manager, right? If the charge nurse is not answering your questions and you feel like you're still not being heard, the charge nurse can, you can ask the charge nurse to talk to the nurse manager. Now, the nurse manager there is usually there during the day. Nurse managers are not typically there in the evenings and nights. But the nurse administrator is, right? So if it's the evening, if it's 10 o'clock at night and your loved one is writhing in pain and his pain is uncontrolled, right? You can ask the charge nurse. If the nurse can't seem to help you, you can ask for the charge nurse and talk to her about the issue with the pain. And if she's not making headway, you can always ask for the nurse administrator. So the nurse administrator is the one in charge of the entire nurse hospital staff for that shift, right? They're the ones dealing with all the admissions, all the ambulances coming in, and they're dealing with all of that. So a nurse administrator, I hope it never gets to that point, but there is a chain of command in the hospital. So let's talk about patient satisfaction for just a minute. It sounds like a beautiful thing, right? Patient satisfaction. We always like patient satisfaction. You need to know that patient satisfaction scores, the hospital has a patient satisfaction score, and those patient satisfaction scores dictate how much Medicare is going to reimburse that facility. So if the patient satisfaction scores are low, their reimbursement rate is going to be low. So hospitals want high patient satisfaction scores. Okay, so if you're not happy, and I don't mean like your dinner was cold, your apple juice was late. I'm talking about delays of care, negligence, these type of things. Then you can ask for a patient advocate. Almost all hospital systems these days have a patient advocate. It's sometimes called the patient satisfaction department. And this is someone who will come and talk to you. They will talk to the patient, and they will help filter through and unweave the mess that has been created. Okay, so a patient advocate would be requested when multiple issues arise, right? It's not just one thing. If it's one thing and the charge nurse took care of it, great. You don't need a patient advocate for that, right? But if it's multiple issues and you're just at your wit's end, just ask, do you guys have a patient advocate I can talk to? Because I feel like I'm not being heard and I just want to talk to them. Multiple issues arise, or when the issues aren't being resolved in a timely manner. You keep getting the runaround, you keep getting delays, you're not being understood, right? Just ask for a patient advocate. Or when you suspect negligence, malice, or discrimination, right? Those are all reasons to ask for a patient advocate, because they're going to be the non-biased person. Even though they work for the system, they're going to be the non-biased person because they don't have skin in the game, right? It's not their loved one, right? And they're going to start to work through and figure out where the ball got dropped.